Assessing medical imaging charges. Healthcare services, like every other business, charge somewhere between what the market will bear and what's required to keep the business in operation. Insurance companies play the other side of that. Negotiated prices between providers and insurers are often nonsensical, chosen just because they make payment negotiations work. Our healthcare spending is staggering. It's close to 18% of the gross domestic product, and even with the Affordable Care Act, this act will only reduce costs at the margins. And yet we will rank below the bottom of all advanced economy nations in the measures of quality healthcare. Today, most doctors and hospitals are paid for each diagnostic or medical procedure performed. The result has been ever-escalating numbers of tests and procedures and greater costs. The U.S. healthcare system operates in a market-driven environment, which can lead to unregulated pricing. Unlike some other countries with more centralized or regulated systems, the U.S. lacks uniform pricing controls. According to research published in the Journal of American Medical Association, JAMA, the U.S. spends twice as much on healthcare as any other high-income country in the world. The U.S. experiences higher prices for medical services, including drug prices, salaries for doctors and nurses, and administrative costs. Procedures, tests, and administrative expenses contribute to the overall spending. Pricing of imaging exams in the United States is often opaque, which leads to confusion and inflated cost. Let's take a look at two examples, MRI and CT scans. Magnetic resonance imaging is usually more expensive than other types of scans. The price for a single MRI scan averaged across hospitals and clinics is about $2,600. However, some MRIs can cost as much as $13,000 each. With the CT scan, the average price of a CT scan in the U.S. can range anywhere from $300 to $6,750, with some scans which can be as high as $20,400. The imaging market in the United States is estimated to generate revenue of more than $100 billion annually, with radiology practices and imaging centers accounting for approximately $23.8 billion of this annual revenue. Overutilization of medical imaging implies wasteful investigations, which increases unsustainable cost in healthcare systems. This often results in a cascade of costly follow-up procedures and services. Imaging technology plays a significant role in this high spending. While utilization of healthcare services in the U.S. is like other nations, medical imaging stands out as an exception. Approximately 40% of imaging volume in the United States is performed at outpatient imaging centers and physicians' clinics. The average profit margins for a diagnostic imaging center can vary significantly depending on the size, location, and management of the center. For instance, industry benchmarks revealed that in 2022, the profit margins range from roughly 12% to 18% for these centers. However, a very profitable radiology center should aim for a profit margin of at least 30%. Now let's take a look at imaging services provided at the doctor's office. Private physicians' offices tend to have lower fees compared to hospitals. Patients may pay for less services as well. Another facet of having the doctor image you and interpret your x-rays is that you're going to only pay one signal copay for both technical and professional services. And finally, pricing is affected at a doctor's office because doctors have fewer administrative expenses and facility-related costs than hospitals or medical centers. The remaining 60% of exams are conducted within the hospital. The hospital has all sorts of imaging modalities for diagnostic testing, from ultrasound and CT and MR to fluoroscopy and interventional procedures. Imaging is a critical component of healthcare, providing essential information for diagnosis and treatment. However, it is also a significant source of revenue for healthcare providers, leading some to refer to it as a cash cow. Currently, medical imaging accounts for approximately $23.8 billion in annual revenues in the United States. When we look at medical imaging costs, we think of high costs. Medical imaging procedures can be expensive, contributing to the cost of healthcare in the U.S. For example, an MRI scan can cost anywhere from $1,000 to $2,500 per session. There are concerns about this cash cow, and one of the big concerns is overuse. The potential for unnecessary scans and overutilization can lead to increased costs and resource use. However, it's important to note that while cash cows can bring in cash for years, new technology or shifting market preferences can eventually render them obsolete. Let's take a look at medical imaging services in a hospital setting. Hospitals often charge more due to their overhead cost, administrative expenses, and facility fees. These fees can be significantly higher from those at other facilities such as outpatient medical imaging and doctors' offices. Hospitals need to maintain consistency in pricing across inpatient and outpatient settings. However, some hospitals create quote-unquote retail rates for commodity services like imaging and lab work to compete with freestanding providers. Medicare and certain private health insurance companies pay for hospitalizations of their beneficiaries using a diagnostic-related group payment system, or a DRG payment system. If a hospital can effectively treat you for less money than Medicare pays for your DRG, then the hospital makes money on that hospitalization. If the hospital spends more money caring for you than the Medicare gives it for your DRG, then the hospital loses money on that hospitalization. In order to figure out how much a hospital gets paid for any particular hospitalization, you must first know what DRG was assigned for that hospitalization. In addition, you must know the hospital's base payment rate, which also is described as the payment per case, and you can call the hospital's billing, accounting, or case management office to find out this information. Medicare and private insurers also have piloted new payment systems that are similar to the current DRG system, but with some key differences, including an approach that combines inpatient and outpatient services in one payment bundle. In general, the idea is that bundled payments are more efficient and result in better patient outcomes than fee-for-service payments, with the provider being paid based on each service that's performed. At the hospital, imaging bills run 2 to 3 times higher than at a freestanding radiology center or a doctor's office. One of the major trends impacting the diagnostic imaging industry is the shift of inpatient volumes away from the hospital setting. Diagnostic imaging volumes have been shifting away from hospital campuses due to the lower cost of performing these procedures at independent imaging centers, with site-neutral payments from the CMS, or Medicare, Medicaid. Patients today are shopping for their healthcare services, and part of their decision is based on cost and convenience. A fee structure that is not tied to the hospital's rates can be more attractive to the patient. Let's take a look at the North American medical imaging market, and we'll start by looking at the compound annual growth rate. This is a way to calculate and determine returns for our investment that can rise or fall in value over time. You'll note that we see 2021 and 2029, and it demonstrates about a 6.3% increase in the growth rate. For more graphic detail, we have the medical imaging segment broken down into different portions: radiology, neurology, gynecology, cardiology, orthopedic illnesses, and urology to get a better idea of the applications being used. In addition, we can note that the United States significantly uses more medical imaging exams than Canada and Mexico. Healthcare versus insurance. Why patients are charged the most for services when they are uninsured. If you have insurance and the provider has a contract with that insurance company, meaning they do include taking that insurance for your service, the contract limits what they can charge and what they will get. The reason for this disparity, let's take a look. The insurance agreed payment does not cover the actual cost of that service for $21 or $26.56. But the provider accepts that because they need the money from overall insurance payments. So let's look at the calculation. Say, for example, the provider needs $26.56 to make a living on. So they lose $5 on every insured customer. 1 in 235 customers has no insurance, and their price is calculated as $26.56 plus 235 times $5, which equates to a $1,200 bill. Insurance companies calculate payments to hospitals and physicians based on several factors. First is fee for service. Under this method, medical providers are paid for each service provided. The payment is determined by the medical reimbursement rate, which is the amount paid per service. For Medicare and Medicaid, the U.S. government sets hospital payment rates. Payment rates for these services are determined based on the relative average costs of providing each to a Medicare patient and then adjusted to account for the other provider expenses, including their malpractice insurance and office-based practice costs. The next method for reimbursement is diagnostic-related groupings. Hospitals are paid based on DRGs that represent fixed amounts for each hospital stay. These negotiated rates can vary widely depending on the insurance company and the specific healthcare provider. Finally, we'll talk about performance-based payments. Some insurance companies use performance-based payment models where providers are compensated according to an evaluation of practice performance defined on certain metrics. In summary, insurance companies calculate payments to hospitals and physicians based on a combination of a fee-for-service rate, Medicare and Medicaid reimbursement rate, RVUs, and DRGs, and then it is all negotiated to create a performance-based payment. Let's take a closer look at fee-for-services. Healthcare providers are based on the number of services they deliver and not the quality of the healthcare they provide their patients. So what we're looking at is really quantity over quality. and this can lead to unnecessary tests and procedures which contribute to overall higher healthcare costs. Medicare and Medicaid are insurances that are provided by the U.S. government. Medicare pays about 20 cents on the dollar for what a healthcare provider bills. So how do healthcare providers normally create a bill? As a result of the 20 cents per dollar paid by Medicare and Medicaid, healthcare providers must artificially increase the amount of money they charge each patient. This means patients insured by other insurers and uninsured patients. Healthcare providers cannot charge uninsured patients differently from insured patients, otherwise they are liable to Medicare, Medicaid fraud by artificially inflating their bills. For Medicare specifically, each element of a medical imaging service is assigned a relative value unit for each current procedural terminology or CPT code. RVU codes are specific for DRG codes and geographic area. Here we see some codes and an adjustment for common high-volume imaging codes. So how does Medicare and Medicaid reimburse medical providers? The RVU codes are adjusted based on geographical practice costs associated with the various geographic areas for different medical cost and wage differentials. The conversion factor is the national dollar amount that is multiplied by the total geographically adjusted RVU to determine the Medicare allowed payment amount for a particular physician service. Here we see an RVU times the conversion factor equals Medicare payment. It would be optimal if only imaging exams were taken when needed. That is not the case. The percentage of medical exams that are requested but not needed can vary, and we're going to take a look at this in the upcoming graphics. The percentage of medical exams that are requested but not needed can vary. A study published in the Journal of Academic Emergency Medicine, which surveyed emergency room physicians, reported that nearly all of the doctors, 97%, admitted to personally ordering unnecessary imaging tests. Another example is research done by the American College of Cardiology Foundation and United Healthcare. They found that 14% of the services performed at the practices studied were inappropriate and 15% were of uncertain appropriateness, which totals 29%. Another example is a Medicare survey, and what they looked at is Medicare beneficiaries with uncomplicated lower back pain. And what they found is 30% of Medicare beneficiaries with the lower back pain were imaged within 28 days of reporting the back pain, even though imaging is rarely indicated in the absence of complications because back pain often resolves itself. Another interesting statistic is that doctors that transition from private practice and go to work for healthcare providers such as hospitals demonstrated that once they were working for that hospital in that environment, they often increased their imaging exams requested. For example, unnecessary MRI referrals increased by more than 20% among those doctors that moved to hospital employment. Finally, let's take a look at a U.S. imaging services market survey by modality between 2020 and 2030, and it is shown in billions of dollars. Each one of these imaging modalities is plotted between 2020 and 2030 with an expected growth 4.3% per year.